So my name is Sharon Hudson, and I'm a palliative care clinical nurse specialist and the community development and partnerships lead at Birmingham St Mary's Hospice. And I'm here to talk to you today about hospice and why we would include even a mention of hospice in your pulmonary rehab sessions. So when you think of hospice, and certainly when your patients and participants think of hospice, the first thing that comes to mind for them is that it means that they're dying. And so we have to think really creatively about how we do that, how we introduce it, how we talk about it, and actually to demonstrate to them the reality of what hospice is and the benefits that that can bring to them. Hospice is typically seen as for people with cancer, for older, frailer adults. People know about our inpatient units. They know about the care that we provide. They know that we do quality of life, symptom management, pain control, and they know that we do end-of-life care. Often what people don't know or understand so readily is the broad range of services that we have in place. Things that are about living well, living for longer, often with an improved quality of life. Things that get you up out of bed, things that keep you going, keep you living well. And within that, we have really very specific services that are focused towards people with long non-malignant diseases and conditions, and in particular for people with respiratory disease. I have a huge interest in the palliative care needs of people with respiratory disease. My dad died of mesothelioma and really quite extreme breathlessness after living for a number of years with COPD. And he did receive palliative care, but it was late, and for him, he was really frightened of it. And I know that that will be the experience of those that you are supporting, even though that's changing. So when I did my master's degree, I looked at the barriers and enablers to palliative care for people with COPD, and there were some general themes that came from that. And what came from that was the understanding. So people with COPD don't understand what palliative care is. They think it's just for the dying. They don't understand the COPD itself and that it can be life-limiting. And so if they don't know or understand that their disease could be life-limiting, then they don't see or recognise that palliative care might be something that is useful or something that's even relevant to them. The same goes to professionals working within our systems and services. So we need to do more to help people to understand what palliative care and hospice care is. When we've done that and when we know that, recognising when hospice or palliative care is something that would be useful or suitable for someone with respiratory disease is tricky. Traditional routes would look at prognosis, prognostication, but you know that that's that point at which you identify that somebody might be moving towards the end of their life is difficult, not impossible. We know there are indicators when their hospital admissions increase, when we know that they're frailer, when we know that they're becoming more breathless despite maximal treatment. But we don't know and we don't recognise. And so what we will often say, and the thing that is threaded through the literature, is that referral to palliative and hospice care needs to be based on need. And that helps you and it helps your patients and those you're supporting, because actually what then happens is that you're referring for a thing. So you're not referring them to general hospice and really adding to their fears that they think this is the end, they think that this is death, but you're saying, I'm going to refer you to this service that's going to help you to manage your breathlessness well, or to help you to think about what's important to you for the future, or to help you when you're struggling psychologically. So think about the needs of your patients and make the referral at that point. The other huge thing is that there isn't a point of referral where your service stops and then hospice or palliative care services start. So what's really important is that you build the relationships with your palliative care and hospice teams, that there's a two-way process and that the care is parallel. So build it together, design together, work together, look at what works for you within your systems and pathways. Okay. So I'm going to tell you two little stories to demonstrate the benefits of referral to hospice and palliative care services. And these stories come from our really great relationship with Paul, who is a real ally to our hospice care services. And we got the opportunity to come to one of his exercise groups some time ago now and to meet this really amazing, funny, vibrant group of people. And we told them about hospice and palliative care, and then they decided they wanted to come down and see us. So they did, and they trotted down in shared cars and on the bus and landed at our day hospice service. And we all learned about each other, and they learned about what we did. And at the end of that session, one of the participants from the group came up to me and said, yeah, this is lovely, it's really nice, but it's not me. I'm not a patient. I don't want to be a patient. I don't want to be the sick person in the chair. This is someone carrying their portable oxygen cylinder and needing a wheelchair. But I'd love to come and help. And so we completed lots of risk assessments and had lots of conversations and got lots of permissions, and she did. She came and volunteered for us, and she managed the reception desk when we had our clinical nurse specialist clinics, and she was an absolute joy to work alongside. And that's said something for us about how we work differently with people, and how the added contribution of supporting and helping others can really help someone. And she stayed helping and supporting us until the week before she died, and she never used our services. The other tale is a conversation I was having with one of our respiratory team leads, who had been preparing herself to have the difficult conversation with someone who was coming up to their respiratory clinic and knew that she wanted them to think about hospice. And so she braced herself and sat down and got ready to have a really courageous conversation with her. And what she found when she started that conversation was that the lady was someone who had come to the hospice, who had been a part of that exercise group, who'd come and had a look round and was really excited, was delighted to have been referred, because she knew that when she came, it was vibrant and it was full of life, and that she would have her needs met. So those shared relational aspects of things helped us all, helped to break down some of those myths and improve communication. And this is our Space to Breathe group. This is a physiotherapist, because we are a multidisciplinary team with lots of therapists and psychological support and social workers alongside our doctors and nurses. And our Space to Breathe program is run by therapists, nurses and social work psychology together. Our program is based on the breathing, thinking and functioning model of breathlessness management, and the link to the outline, the evidence that sits behind that is there. And so the model is designed for people who have often been through pulmonary rehab or haven't accessed it for all sorts of reasons, but are really struggling with breathlessness that's tied in with loss of function and anxiety and some of that disordered thinking and thoughts that come with that. And so what we do with the program is to work with giving people back control of their breathing, giving them hints and tips and peer support around how to function and improve functioning, which includes an element of exercise, We worried a little bit about that at the beginning, as lovely hospices who wanted to be kind. But actually, the design of the program that we built was with the respiratory team, who really pushed us to include exercise, and it was absolutely the right thing to do. And we work to look at the psychological components and the thinking and the feeling that comes alongside panic disorder and breathlessness, and help people to think about and manage that. We do that alongside the carer, because what we know is that for carers, they are often the person that's left at 3 o'clock in the morning with their loved one who is distressed and can't breathe. So we take them through steps that support that. So there's lots of really lovely evidence that looks at that model and looks at the improvements that that's made, not necessarily to the breathlessness function. So it doesn't improve their breathing function necessarily. It can, but doesn't always. But what it does give people is a sense of control of their breathing. So their perception of breathing, how they manage that, how they continue to live their lives. So I would suggest that you look at whether your local hospice service has provision for this, and maybe engaging some conversations where you could do this together. Building into your PR sessions, would really love you to think about advanced care planning. You may do this already, but the advanced care planning that's beyond just DNA CPR or respect discussions, but that really focus and look on what matters to the person. So that might include, care provision, who's going to be looking after them at their end of life, what who's important to them, what that looks like, but also, what matters in their life, what do they love, how can you make sure that they are able to build those things into their life now, and that's shared with others so that everybody knows that. So just those personalized care conversations that, yes, include the components that are about care and dying, but actually also include what's really important to them and what's mattered. So beginning those conversations in your pulmonary rehab sessions can actually then lead to conversations about what is available out there by way of hospice and palliative care services, and to break some of the myths that sit around that. This is our fabulous hospice, which is full of life, genuinely full of life. And I would recommend that you make contact with your hospice and build the relationships that you need to be able to do this work together. And then when you are talking to the participants of your sessions, that you're able then to do that in a way that they know that you're part of that partnership. So it's not something that you're referring on to that they're scared of. Thank you for listening today. You can catch me on Twitter these days at Shazza Hudson. So if you want to ask any questions, continue the conversation, then please do get in touch with me or via Paul. Thank you for listening today, and I hope that you enjoy the rest of your